Welcome to The Explainer. Today, we're going to put on our detective hats and crack a really important case in liver disease. We're going to follow the clues, starting with this one major sign that tells you a patient's liver is in some serious trouble. All right, so let's just jump right in with a big question. When a liver starts to fail, what they call decompensate, it starts sending out distress signals, right? But which one is the first to pop up? Figuring that out is absolutely key if we want to intervene early. Okay, so let's talk about that word for a second, decompensation. What does it even mean? Well, it's basically the tipping point. It's when a liver that's been sick for a while just can't keep up anymore. It can't do its job, like making proteins or cleaning toxins out of your blood. It's a huge turning point for a patient, and it shows up in a few classic ways. And here they are. You can think of these as the four horsemen of liver decompensation. You've got bleeding from varices, you've got jaundice, hepatic encephalopathy, which causes confusion, and then there's ascites. That's the one we're focused on, the fluid buildup in the belly. Now, they're all super serious, but here's the kicker. Ascites, that is so often the very first sign we see. That's our big initial clue. Okay, so we've found our first clue, ascites. The patient's belly is swollen with fluid. But that just leads to the next big question, right? Why is it there? What's causing it? And to figure that out, we have this incredibly elegant, super powerful tool we can use. It's called the SAAG. That stands for Serum-Ascites Albumin Gradient. And honestly, it's just as simple as it looks right here. You take the albumin level from the patient's blood, and you subtract the albumin level you find in the fluid you just took from their belly. That's it. And that one little number, it's the key that unlocks the whole diagnosis. So why is this one number such a game changer? It's all about that 1.1 cutoff. If your SAAG is high, greater than 1.1, that tells you there's a huge pressure difference. It's almost always from something called portal hypertension, which you see in cirrhosis. All that pressure is literally squeezing low-protein fluid out into the abdomen. But if the SAAG is low, that tells a completely different story. It means the pressure gradient isn't the problem. Instead, something else is causing protein-rich fluid to leak out, things like cancer or an infection. See, it's the fork in the road that tells us exactly which path to investigate. All right, so we've used our trusty SAAG. We've confirmed the ascites is probably coming from liver disease. So, now what? How do we get rid of it? Well, it's not a one-size-fits-all kind of thing. It's more like climbing a ladder. We start at the bottom rung and work our way up based on how severe it is. And you can see how we climb that ladder right here. For grade 1, which is pretty mild, we start simple. Just cut back on salt. Easy enough, right? The goal is to get the body to hold on to less fluid. If that's not enough and we're at grade 2, we bring in the big guns, diuretics, specifically spironolactone and furosemide. They work as a team to make the kidneys flush out extra salt and water. But for grade 3, when things are really severe, we have to get more aggressive. We can either do what's called a large volume paracentesis, which is literally draining liters of fluid out with a needle, or we start thinking about a TIPS procedure. That's a stent that goes right into the liver to relieve that pressure at the source. But, what happens when that treatment ladder breaks? What if the diuretics just stop working? That's what we call refractory ascites. It's a tough spot. It means either the patient's body is completely resistant to the meds, even at the highest doses, or the side effects are just too much for them to handle. This is a really serious sign, and it's when that TIPS procedure we just talked about becomes a much more serious option. So just when you think you're getting a handle on all this fluid, a new, even more dangerous problem can show up. See that big pool of fluid just sitting in the abdomen? It's the perfect breeding ground for bacteria. And when that happens, we're dealing with something called spontaneous bacterial peritonitis, or SBP, and it is a huge deal. So if you have a patient with cirrhosis and ascites and they suddenly spike a fever with chills, or start complaining of belly pain, or just look really sick, like they're heading into sepsis, man, alarm bells should be going off like crazy. These are the classic red flags that the fluid has gotten infected. It's a true medical emergency. Okay, so the suspicion is sky high. The patient looks sick, the story fits, but as clinicians, we need proof, right? How do we confirm with 100% certainty that it's SBP? Well, we have to go back to the source. We've got to test that fluid again. And our first big clue from that fluid is this number, 500. If the total white blood cell count in that acidic fluid is over 500, our suspicion for infection just went through the roof. It's a clear sign the body's immune system has rushed its soldiers into the fluid to fight something. But we can get even more specific. And this number right here, 250, this is what closes the case. We're looking at a specific type of white blood cell, a neutrophil or PMN. If that count is over 250, that's it. That is the diagnosis of SBP. It's so definitive you can start treatment immediately. You don't even have to wait for the cultures to grow. This is our smoking gun. So once we've got that confirmation, the game plan is super straightforward. It's a two-phase attack. First, you hit the active infection, and you hit it hard. And second, because this stuff has a nasty habit of coming back, you have to put a plan in place to prevent it from ever happening again.
So for phase 1, treating the active infection, our go-to weapon is ceftriaxone. It's a powerful, broad-spectrum antibiotic we give through an IV. It's really good at knocking out the usual suspects like E. coli that cause this mess.
Then for phase 2, prevention, once we've cleared up that initial infection, we can't just walk away. These patients are often put on a long-term, low-dose antibiotic like norfloxacin. Think of it like a shield, right? It's our prophylaxis to help stop another dangerous round of SBP from starting. And really, this brings us all the way back to the beginning. This idea here is so important. Identifying ascites isn't just about spotting a symptom. It's about recognizing a critical window of opportunity. That earliest sign is your first and maybe your best chance to step in and really change the direction this disease is heading. So let's leave you with this final thought. We've walked through the whole case, from finding the first clue of ascites to treating a life-threatening infection. But as chronic liver disease becomes more and more common out there, the really big question for all of us is this: how can we as a healthcare system get better at catching these signs earlier and managing these incredibly dangerous complications more effectively for every single patient? Thanks for joining us for this explainer.